Hello there. This is Chapter 28 review. This is dealing with diagnostic parasitology. So all about parasites. It is a large and very detailed chapter, once again, and it has tons of information. So I'm just going to briefly touch on all of the different topics in your PowerPoints and some of the more specific details I want you to know about the different organisms we'll discuss. So let's get started. Parasites. Parasites can infect several different body sites. So some of these body sites include the respiratory tract, the gastrointestinal tract, the urogenital tract, your blood, CSF, and tissues, muscles. So those are just some of the areas of your body that these can infect. I think the first thing we'll talk about are intestinal parasites. We'll talk about a few other intestinal agents or infective agents later, but they're classified as something else under the helminths part of this chapter. So the first thing we'll talk about are protozoa, intestinal amoeba. So an amoeba is a single-celled organism that can be free-living or parasitic. So it can be either or. Before we go on, I just want to talk about some collection and transport and handling when involving parasites in the clinical lab. So for fecal specimens in particular, a single stool is rarely effective for identifying and isolating intestinal parasites. Usually you have to have a collection or series of 3 different stools within 10 days. So this is the best method for recovery of parasites. Of course, it has to be in a clean, dry container. Ideally, one that includes preservative. So there are several different types of stool collection containers we use in the lab, and one is particularly useful and helpful for preserving ova and parasites. Let's see. Never should we collect stool from a bedside pan or the toilet bowl. And of course, we should collect stool specimens before any kind of antibiotic is given to the patient. So some of the preservatives we can use to preserve stool, most commonly we use a PVA or a polyvinyl alcohol. This can make permanent stains. So this is used for like a permanent staining wet prep almost, if you were to classify it. There is a formalin preservative, of course, 10% used for wet mounts and concentrated preparations. And then there's the Parasafe, or we call it the Parapack. This replaces both the PVA and the formalin, and it's safer for the laboratory technician because it's not carcinogenic and it does not contain mercury. So this is the most common one you'll see is a Parasafe container. So regardless of the preservative used, there is a standard ratio. The ratio is 3 parts fixative to 1 part stool specimen. So remember this, for optimal fixation of fecal specimens, 3 parts to 1 part. 3 part preservative, 1 part stool. So macroscopically speaking, we'll look at that stool when it arrives in the lab, and you'll look for things like color, consistency, bloodiness, mucus present. And this helps to determine what stage of organism you might find it in. Soft or liquid stools, you'll primarily find motile protozoan trophozoites, or we call these trophs, and these are the active feeding form of the organisms. Formed stools primarily these would contain inactive cysts. So it's important to macroscopically know what kind of stool specimen you're working with. Microscopically, we do not perform gram stains, if you remember correctly, because there's a plethora of bacteria in stool, and so it's not a practice we perform. But we do microscopic exam when looking for ova and parasites. There are several methods used. One is a wet mount. Another one is a concentration technique. Another one is a permanent stained smear. And then there is one we do for a particular organism called a pinworm, and that is a cellophane tape prep method that we actually perform in the tape. If it collects any eggs or ova, you put it directly onto a slide and view it under the microscope that way. So that primary first method, the wet mount prep, we usually use this to detect motile trophozoites, like I mentioned earlier. Wet mounts can be made in saline or iodine or a combination of both. We look under low and high power. We do not use oil immersion for this examination. The second method is the concentration technique. Trophozoites do not survive concentrations. However, cysts and larvae in eggs are usually detected by this method. There are two techniques used for concentration. There are the sedimentation method, and then there is the flotation method. The sedimentation method concentrates a greater diversity of organisms at the bottom of the tube. There are a few things that there are a few reagents that we use for sedimenting, and that's formalin ether, formalin ethyl acetate, and then the Parasafe reagent. So all those are compatible with sedimentation methods. The flotation method, however, suspends the organisms at the top of a high density fluid. So they'll float. A couple of reagents we use for this method are zinc sulfate and Schieffer sugar. A third method for microscopic examination is a permanently stained smear. So these smears are used to detect and identify trophs and cysts. We most commonly use something called Wheatley trichrome. It's the most common permanent stain used, and it will uniquely stain characteristics, like the cytoplasm will stain blue-green, nuclear structures and red blood cells will stain this dark purple red, and the eggs and larvae stain red, and the background debris and yeasts will stain green. So with this method or staining technique, we would examine first under low and then use oil immersion under high to identify structures. There is another staining method, and this is the modified acid-fast stain. So it's a modified Kinune procedure using 1% sulfuric acid or H2SO4 as the decolorizer. And this can detect oocytes of Cryptosporidium, Isospora, and Cyclospora species. Let's see. And then that fourth method I mentioned for microscopic exam was the cellophane tape prep for pinworms. And so what we do is we swab the perianal area with a tongue blade covered with a cellophane tape, sticky side up or out. So we were trying to get any kind of cysts or eggs to stick to that tape, and then we take that sticky side of the tape and place it on a microscope slide and examine it under low and high power. And you look for these characteristic flat-sided eggs. So let's see. There's another unique test we can use for intestinal parasites. It's not a microscopic test. It is something called the Entero test or the string test. And so what this involves is a gelatin capsule that has a coiled string inside of it. And part of that string is, the end is coming out the bottom of the capsule. So you tape the string that's coming out of the capsule onto the patient's face. And then you have them swallow this gelatin capsule. It will go down into their GI tract. You leave it there for approximately 4 hours, and then you pull it out. And then you can use that string to either look at under a wet prep or to clean off the string, and whatever matter is with it you would view under a wet prep. And this is essentially looking for parasites, cysts. So that's intestinal parasites. So to collect and look at some of the other parasites that can infect the human body, we would have to do some blood smears, maybe examine CSF, tissue biopsies. When dealing with blood smears, so when looking at blood smears, blood is taken directly from a finger stick, which gives the best staining characteristics in this particular method. Giemsa or Wright stains are the most commonly ones used. When preparing blood for blood smear examination, we do a thin and a thick area on the slide. Thick film part is best for parasite detection. Organisms are concentrated in a relatively small area, but then the thin area, the thin film area, is very important for species identification. You can see the single organism or cyst that you're looking for. So this is best for species ID. So like I said, we could do biopsies of tissue, muscle, CSF is another one. So there are a couple of immunotests for or methods used to ID different species that are parasitic. One is the enzyme immunoassay, or EIA. This is the most common one we use in our area. And this looks for different organisms like Cryptosporidium, Giardia, Entamoeba histolytica, Wuchereria, and Trichomonas. And then there's also the fluorescent antibody technique, or FA. And this also can detect Cryptosporidium, Giardia, and something called Pneumocystis. It's always handy to have a reference guide with pictures, a collection of parasites to always reference or have available to reference. So it's important to have those nearby when you work in a department that does parasite ID or detection. Okay, so back to the types of organisms that we call parasites. Intestinal amoeba, single-celled eukaryotes. They're either free-living or parasitic. So these are single-celled animals that catch food and move about by extending finger-like projections of protoplasm. There is only one true pathogen that is an intestinal amoeba, and this is Entamoeba histolytica. So know this, one true pathogen will infect anybody. There are several non-pathogens that we'll discuss, and then there are some that are opportunistic. So some general characteristics of amoeba. All of the ones I'll talk about live in the large intestine. They possess both a trophozoite and a cyst stage. So a trophozoite is a motile active feeding stage of an organism. A cyst is a resistant stage that is infective for humans. So it is like a spore, like in the last chapter, but it's a cyst, it's an egg. Species identification often rests on the size, the number of nuclei present in their cyst, nuclear structure, and the presence of particular nuclear structures. So the general life cycle of amoeba is the human ingests an infective cyst via food or water. It will develop into the trophozoite, which is the active feeding form, and become something called an egg cyst. The egg cyst will infect or travel down into your intestine, where it will produce more cysts. The cysts and trophozoites are passed in the stool, or they can leave the intestine through damage of your cellular tissue, and go into the bloodstream, which at that point they can infect other organs, commonly the liver, like a hepatic abscess can form. So that's the general life cycle. It will continue to release more organism or cysts through the stool, and enjoy its habitat. So let's talk about a few organisms. The first one being our true pathogen, and that's Entamoeba histolytica. So this one's found worldwide, especially in the tropics and subtropics. It is the major amoebic pathogen for humans, the third most common cause of parasitic death. It causes something called amoebic dysentery, and produces a characteristic flask-shaped ulcer in the intestinal lesion. Organisms can penetrate the intestine, so they damage that intestine wall and proceed to the liver to form abscesses. So it has both a trophozoite and a cyst stage. The trophozoite is fairly large, 10 to 50 micrometers. It has a characteristic bullseye nucleus with even fine peripheral chromatin. Ingested red blood cells are diagnostic for Entamoeba histolytica trophozoites. So you will find these trophozoites with ingested red blood cells. The cyst form of Entamoeba histolytica is 10 to 20 micrometers, fairly smaller than the troph stage. It contains 1 to 4 nuclei. 4 is most typical for this organism. It has a small central karyosome and fine, evenly distributed peripheral chromatin. Cytoplasm of this cyst may contain a cigar-shaped chromatidal bar with rounded ends. The next organism I'm going to mention is Entamoeba hartmanni. This one, it also has a nickname called small race. It's very similar to Entamoeba histolytica. However, this one is non-pathogenic. It's the only thing different about this organism versus Entamoeba histolytica is that this one is much smaller. Its trophozoite size is 4 to 12 micrometers, and the cyst is 5 to 10 micrometers, so much smaller. The trophozoite in this organism, Entamoeba hartmanni, has a large nucleus, eccentrically located karyosome, and coarse, uneven peripheral chromatin on the nuclear membrane. So one little bit different, but much smaller. very similar to Entamoeba histolytica. The next organism I'm going to mention is Entamoeba coli. This organism has a mature cyst with 8 nuclei. It has an eccentric karyosome and coarse, uneven peripheral chromatin. It has chromatidal bars, when present, that have a splintered appearance. The next organism, intestinal amoeba, is Endolomax nana. So trophozoites of this organism are 5 to 12 micrometers. Cytoplasm is granular and vacuolated. The cyst stage of Endolomax nana is oval or spherical, and these are about 5 to 12 micrometers in size. Next organism is Iotamoeba buchili, or buchilii. Trophozoites of this organism are they have a single nucleus with single irregularly shaped chromosomes, and they're about 6 to 20 micrometers in size. Cysts of Iotamoeba buchilii are oval with a size of 6 to 15 micrometers. They have a large, well-defined glycogen vacuole. Important note, so they have this glycogen vacuole. The next organism I want to discuss, that's the intestinal amoeba, is Blastocystis hominis. This was once thought to be a yeast, but it is a protozoan, possible cause of diarrhea in humans. There are 4 forms that exist. It exists in an amoeboid trophozoite form, a granular, vacuolar, and cyst form. So it has 4 different forms. It's about 5 to 15 micrometers. It cannot have up to 4 nuclei, but usually they're pushed to one side of that cyst, one side of the cyst. And it has a large central body. So that is the intestinal amoeba that we just talked about. We're going to talk about a few tissue amoeba, and then we will move on to some, the tissue amoeba includes blood and tissue. And then we'll move on to some helminths or some worms. Okay, so tissue amoeba. There are 2 primary that I first want to talk about, and that's Naegleria fowleri and Acanthamoeba. Naegleria fowleri causes primary amoebic meningiocephalitis, or PAM. It occurs in children and young adults usually, and it is common after a recent swimming event in warm water, artificial lakes, or brackish, muddy water, so stagnant water places that are real warm. This life cycle has 3 stages: free-living trophozoite, transient flagellate form, and an environmentally resistant cyst form. So the way that this infection will progress is it'll enter the nasal cavity, colonizes in the amoebic form. It will penetrate your cribriform plate, move along the olfactory nerve, and invade your central nervous system. And then it will infection will mimic bacterial encephalitis. So it's a very serious infection when this occurs. So that's tissue amoeba, Naegleria fowleri. The second tissue amoeba, well, let's talk about how we would diagnose that Naegleria fowleri in the lab. We would find motile trophozoites in CSF fluid. They're fairly large at 10 to 12 micrometers, or well, maybe a medium size, 10 to 12 micrometers. And they extend these large pseudopods for movement. The next tissue amoeba is Acanthamoeba, and this causes something called granulomatous amoebic encephalitis, or GAE. This usually occurs in immunocompromised patients, It spreads to the CNS from primary inoculation site in the lungs or the skin. It can also cause amoebic keratitis, which people who wear contact lenses are the ones at risk for this. So homemade saline solutions are the culprit most of the time that this is seen. It causes an amoebic keratinitis in the eye. To diagnose Acanthamoeba species, the troph is 10 to 45 micrometers, has a single nucleus with a central prominent endosome. The cyst is 10 to 20 micrometers, spherical and double-walled. The walls have this wrinkly appearance, so characteristic. Let's talk about some ciliates. The only ciliate that is pathogenic for humans is an organism called Balantidium coli. Balantidium coli. Hogs are the true host. Human beings are accidentally infected or hosts. Their very large trophozoite stage has a size of 90 by 60 micrometers. They are cilia-lined with a cytosome located at the slightly pointed anterior end. The cyst of Balantidium coli is thick-walled, average size of 45 to 75 micrometers. In both stages, trophozoite and cyst form have two nuclei that are kidney bean shaped. Well, let me back that up. They have two stages of nuclei. The first one is kidney bean shaped, and that's what they call the macronucleus. And then the second stage is called a micronucleus. It's very small. Okay, so let's talk about some pathogenic flagellates. Okay, you know what flagella are. So these are flagellated organisms that can infect the intestines or the urogenital tract. They're a very simple life cycle in general. They resemble that of the amoeba. Most flagellates have both a trophozoite and a cyst stage. The first flagellate we're going to talk about is Giardia lamblia. This causes gastroenteritis. It's also known as traveler's diarrhea. It is the most commonly reported intestinal parasite in the U.S. Animals serve as reservoirs, contaminated rivers and streams as well. Clinically, Giardia lives in the duodenal area of the small intestine. It's usually a self-limiting diarrheal disease, lasting like 10 to 14 days. You have explosive, very foul-smelling diarrhea, usually yellow in color. Feces are usually the diagnostic specimen. A duodenal aspirate or an enterocyst may be used to isolate the organism, or enterotest is used to isolate this organism. Let's talk about the classic appearance of the Giardia lamblia trophozoite stage. They are pear-shaped, bilaterally symmetric, 9 to 21 by 5 to 15 micrometers in size. They are the characteristic falling leaf motility. They have a binucleate troph with large central karyosomes. They have 4 pair of flagella. They often are called the old man's face because of the way that they appear. It almost looks like they have 2 eyes. Let's see. The cyst form of Giardia lamblia is oval, about 10 by 8 micrometers in size. They can have up to 4 nuclei. Okay, the next organism to mention that is a flagellate is the Dientomoeba fragilis. This is now recognized as a cause of gastrointestinal illness. So it's more of a currently discovered GI illness causer. It lacks a cyst stage, so this is unique. The trophozoite stage is the only one that it's known to have form of. Its trophozoite stage is binucleate with no peripheral chromatin. It can be anywhere from 5 to 12 micrometers in size. There's another flagellate that does not have a cyst stage, and that is the next flagellate we'll talk about, and this is Trichomonas vaginalis. Trick is what we call trick. This is a pathogen of the urogenital tract of men and women. It is a STD, one of the most common. It lacks a cyst stage, like I said, so the only form is the trophozoite stage. Let's see. In women, the infection is primarily localized in the vagina, resulting in itching and a creamy discharge, as well as painful urination. Men are usually asymptomatic and serve as carriers. They may develop nonspecific urethritis with some form of milky discharge. Organisms can be seen in urine and these discharges. The trophozoite stage of a Trichomonas vaginalis organism is pear-shaped, about 5 to 18 micrometers. It can be found in urine and vaginal discharge, like I said, and prosthetic secretions. There are 4 anterior flagella and an undulating membrane that extends half the length of the body. There's a single nucleus present, so oftentimes when you're looking at this under the microscope, doing a urine microscopic or a wet prep, vaginal wet prep, these things are very motile. So they kind of just bounce around, vibrate, if you will. However, this energy is short-lived and they will die. So it's very important to find these in a wet prep and process those specimens very quick, because after they die, they appear to look like white blood cells, and so they're very hard to identify after they have died or have exhausted all their energy. So it's important to process these quickly so that you can find them and know for sure that's what you're looking at. Let's talk about some blood and tissue flagellates. There are 2 genera in particular. There's Leishmania and Trypanosoma. They're transmitted by insect vectors, which are necessary for the completion of the life cycle. They have different life cycle stages for diagnosis. However, this is important. There is a mastigote and a trypomastigote stage that are diagnostic stages found in humans. The amastigote is an obligate intracellular organism, this stage. It is an obligate intracellular organism found within macrophages. You can find these in the liver or the spleen cells, bone marrow, or primarily these are found in diseases with Leishmania. The trypomastigote stage in a human is a flagellated form found in blood, lymphatic fluid, and CSF, usually infected by the genre Trypanosoma. So let's talk about Leishmania first. So Leishmania, they refer to these as complexes, in a man. So there's a slide that has Leishmania complexes. So they are kind of like a grouping, I suppose. The first one is called Leishmania tropica complex. So this causes cutaneous leishmaniasis, or something called oriental sore. The second one is Leishmania brasiliensis complex, and this causes a mucocutaneous leishmaniasis, or Espondia, found in Mexico and Central and South America. That oriental sore, or tropica complex, is found in the Orient and North Central Africa. So the third complex is Leishmania mexicana complex, and this is the cause of New World leishmaniasis, found in Central and South America. And then the fourth complex is Leishmania donovani complex, and this causes visceral leishmaniasis, or Kala-Azar, which goes to the liver, bones, and spleen. This is found in South America, Africa, and Southern Europe. So let's see, the life cycle of Leishmania includes so an insect vector, such as a fly, will bite a human, regurgitate some of the promastigotes that are living inside this host vector. So it will regurgitate these promastigotes into a human skin. The promastigote is phagocytized by a macrophage and then transformed into an amastigote. The amastigote will multiply intracellularly, and then eventually will so after the amastigotes replicate inside of the body, the human body, another fly, particularly the sandfly, will bite the human, ingest those infected macrophages, and then serve as a vector once more. So once these amastigotes are ingested into the fly, the amastigotes transform into promastigotes once again in the gut of the fly, and then they will divide in that fly's gut and migrate to the proboscis once more to reinfect another human in the promastigate stage. So what they do is it's when they take their blood meal from a human, they infect the human, and then the human infects the fly, another fly, and then it just continues on in this cycle. So amastigotes versus promastigotes, they look quite different. I believe you have a picture. The promastigotes look long and thin with a flagella. So let's talk about trypanosoma organisms. These cause sleeping sickness. So there is a couple in particular. Trypanosoma brucei gambiense causes West African sleeping sickness. And then the Trypanosoma brucei rhodesiense causes East African sleeping sickness. Rhodesiense, I said that wrong, sorry. Trypanosoma brucei rhodesiense. So that causes the East African sleeping sickness. This one in particular is more severe, often resulting in death in 1 year. Game animals serve as an important reservoir host for this particular organism. The vector of trypanosoma sleeping sicknesses is the tsetse fly. Diagnostic stage in humans is the trypomastigote. The sleeping sickness life cycle, similar to that of the leishmania life cycle, and involving that tsetse fly. So the tsetse fly will bite the human, just like the sandfly in leishmania, and would ingest the trypanomastigotes or trypomastigotes. Where was I at? Okay, so infected human. Let's back up. Let's start with a fly. Okay, so say the fly is infected first. This is our vector. The fly will bite the human. Usually in this form, it's not the proboscis and regurgitation that occurs. It usually will defecate on the surface of the skin while consuming its blood meal from the human. And then it's after the fact that the human will itch that bite area and scratch the stool or feces of the fly into the wound. And that is how the organism enters the human most of the time. So once these trypomastigotes have entered the human, they transform into different intermediate stages. Will infect various cells and circulate throughout the body and the blood. And then a fly that's not infected, a tsetse fly, will bite a human that is infected and will acquire the trypomastigotes in their blood meal. And then in that tsetse fly, it goes through various forms or intermediate forms. They transform into inside the fly's midgut into something called epimastigotes, and then the epimastigotes multiply in salivary glands, and then they transform into these trypomastigotes again. So this cycle is continuous. It never really ends because the fly needs blood meals. But anyway, that's trypanosoma's life cycle, similar to that of leishmania. So one organism I want to talk about is Trypanosoma cruzi. This causes something called Chagas disease, found in rural areas of Mexico and Central and South America. It's transmitted by the reduvid bug, also known as the kissing bug. It has been transmitted by blood transfusion and congenital infection in some situations. The primary diagnostic stage of Trypanosoma cruzi is the trypomastigote appearing with a large nucleus. There's something called xenodiagnosis that I want to mention, and this is used in Central and South America as a diagnostic method. So they use these lab-raised bugs that they feed on a patient suspected of being infected with Trypanosoma cruzi. So there's kind of a sterile bug that they know do not have these parasites in them. They let them bite a person suspected of being infected, and then the insects are returned to the lab and the feces are examined for trypomastigotes. So if the feces present with trypomastigotes, then it's kind of diagnostic for the patient having this infection. There is a phylum called Apicomplexa, and this phylum of parasites includes blood and tissue parasites. The human may serve as a definitive host when sexual reproduction takes place, and as an intermediate host when asexual reproduction occurs. Organisms in this phylum can affect different body sites, such as blood cells or cells of the intestinal tract or different organs. So some of these species I'm going to talk about that are in this phylum Apicomplexa are quite severe. There are 4 Plasmodium species I want to talk about, and these cause malaria. Plasmodium species are the most common cause of parasitic death worldwide. Transmission of Plasmodium species occurs through insect vector, and the insect is the Anopheles mosquito. So it's a blood transmission. Infected needles can also transmit this disease. So usually we ID this by examination of a right stained blood smear. Clinical infections with the group or genre Plasmodium involve the erythrocyte blood cell cycle. So it's linked to red blood cell rupture and release of these merozoites. You'll have chills followed by fever. This can last from 2 to 20 hours, and then the cycle repeats at regular intervals. There are 4 species we'll talk about: Plasmodium vivax, Plasmodium malariae, Plasmodium ovale, Plasmodium falciparum. Falciparum causes the most severe infection. Usually it's a cerebral malaria. Another complication from Plasmodium falciparum is something called black water fever. Chloroquine remains the primary drug for prophylaxis and treatment for this disease or infection. There are life cycle stages of malaria that have these different terms I want you to be aware and familiar with. There's a ring-formed trophozoite. There is a mature trophozoite. There is an immature schizont. There is a mature schizont, which contains the merozoites. There are 2 other terms, microgametocytes for the male and microgametocytes for the female. So this is talking about well, we'll get back to that. Anyway, okay. So let's continue on. The Plasmodium life cycle, key points to this is that the asexual reproduction, schizogeny, occurs in humans in 2 phases. There is an exoerythrocytic phase, which takes place in the liver, and then there is an erythrocytic phase, which takes place inside your red blood cells. That's asexual reproduction. Sexual reproduction with Plasmodium reproduces sporogeny, and this takes place inside of the mosquito. So when this is suspected, when infection with malaria is suspected, a history of travel to an endemic area must be made. And then there are classical clinical symptoms that usually alert the clinician. We do a thick and thin smear of the blood, and you may be able to see trophozoites, schizonts, and gametocytes on a blood smear. Let's talk about each one of these 4 species. Plasmodium vivax has something called a tertian life cycle. It takes 48 hours. It invades young red blood cells, often 1.5 to 2 times larger. So it has, it's usually found in your larger red blood cells, the younger ones. There will be presence of pink stippling, or also known as Schufner's dots. Young trophozoites appear amoeboid. Mature schizonts have 12 to 24 merozoites. So these are just some facts you need to relate with Plasmodium vivax. Plasmodium malariae has a quarton life cycle, and this is 4 days. So this occurs every 4 days. It usually invades the older red blood cells, this organism. It has a compact trophozoite, so it may have a characteristic band appearance. It has dark, coarse brown pigment that may be present, and these are called Siemens dots, unlike your Schuffner's dots. These are Siemens dots. A mature schizont of this species has 6 to 12 merozoites and may be in a daisy petal arrangement. So know those characteristics. Plasmodium ovale has a tertian life cycle, so about every 3 days. Red blood cells are enlarged and may exhibit fringing. Mature trophozoites are usually oval. You can see Schuffner's dots in these as well, less common than with Plasmodium vivax species. And the schizont has 6 to 12 merozoites. Plasmodium falciparum has an irregular life cycle, so it has irregular timed fevers that go along with this infection. They're usually only ring trophozoites, and gametocytes are found in blood smears. The ring trophozoites look like headphones when you see them inside of a red blood cell. Let's see. Delicate ring forms, multiple rings, signet rings, and applique forms have also been seen. Gametocytes have a typical banana or crescent shape. So know those characteristics that distinguish each one of those species. Let's talk about something called Babesia microti. This is an organism, has an insect vector as the Ixodes domanii tick. Malarial symptoms are usually mild. Person may be asymptomatic even. There is no exourethrocytic cycle in humans, only endourethrocytic or erythrocytic. There's small, delicate ring forms that are seen. Mature trophs may have a classic tetrad or Maltese cross form. Another blood tissue species is Toxoplasma gondii. This is found worldwide. More than 20% of people in the U.S. have antibodies to this organism. The household cat is the definitive host. This is why it's important for pregnant women to not change kitty litter or come in contact with cat feces while pregnant, because it can cause complications with a fetus. So usually humans acquire it by ingesting or inhaling oocysts from cat feces. And it can be transmitted to the fetus. So there's some opportunistic intestinal apicomplexa that I want to talk about or briefly mention as well, and that's Cyclosporidium parvum and Isospora belii, or belii. Cryptosporidium parvum is recognized as an animal parasite. Let's see. They're a zoonotic infection. And then, let's see. To diagnose a Cryptosporidium infection, we would use the Schieffer sugar flotation method to concentrate stool. Trichrome is not useful. It's best detected in fecal smears using the modified acid fast method. So this infection is transmitted by ingestion of an infective oocyte or infected municipal water supplies. There's massive fluid loss with infection from this. They're cholera-like diarrhea. So usually immunocompromised patients are higher at risk for Cryptosporidium infection. Isospora bili and something called Cyclospora cayetanensis. These are usually clinically indistinguishable from Cryptosporidium. They cause common disease, a common disease to that Cryptosporidium. So enough about those. Let's talk about helminths. Okay, these are worms. These include flukes, roundworms, and tapeworms, also hookworms and threadworms. Humans become infected with a helminth by ingesting the egg or ingesting larvae in an intermediate host, or possibly direct larval penetration of the skin. Severity of an infection from a helminth is usually related to the number of adult worms present, which we call the worm burden. First group we'll talk about are flukes. Flukes are also known as flatworms. They can be anywhere from millimeters in size to 8 centimeters in size. Important note about these flatworms: in all species of flukes, eggs must reach water to mature, and all flatworms have a snail species as their first intermediate host. That's an important note. There are different types of flukes. So we can have intestinal flukes, liver flukes, lung flukes, and blood flukes. There are 3 intestinal flukes I'll mention, 2 liver flukes, 1 lung fluke, and 3 blood flukes that we'll talk about briefly. Just know that all flukes have a snail species intermediate host, and eggs must reach the water to mature. So the first one, this is the intestinal fluke group, is Phaseolopsis buski, and this is also known as the giant intestinal fluke. Found mostly in Asia, dogs and pigs are reservoir hosts. Humans acquire it through ingestion of contaminated vegetation. Finding an egg is diagnostic. Very, very large eggs with an operculum. An operculum is like a flap or opening. So this is where the worm can release. So an egg with an operculum flap is very large for this species. The next intestinal fluke. Well, I'm going to talk about the next fluke in general. And this is a liver fluke. And this is Phaseola hepatica, and this is the sheep liver fluke. Causes liver rot in sheep. Eggs are virtually indistinguishable from Phaseola buski, or Phaseolopsis buski. Let's talk about the Chinese liver fluke, and this is Opisthorchis sinensis, and this is limited to the Far East. Dogs and cats serve as a reservoir host. Adult organisms live in the distal bile ducts of the human or of the dog and cat. The egg is 29 to 35 micrometers long. Egg is flask-shaped with prominent shoulders. It has a small knob, often seen on the opposite end. That's another liver fluke. So your 2 livers. Let's talk about the lung fluke, and the one that causes this is Paragnomus paragnemus. Sorry, these are hard to say sometimes. Westermanni. So Paragnemus westermanni. Paragnomus. It just depends on how you pronounce it, I guess. Paragnomus westermanni. Primarily found in the Orient. Let's see. Sputum is the primary diagnostic specimen. Eggs can be found in feces if swallowed. They have a very large egg with a flattened operculum or flap and slight shoulders. So let's talk about some blood flukes. These are your Schistosoma species. There's 3. There's both a male and a female form. The eggs are unoperculated, so they do not have a flap opening. Human beings are infected by direct penetration of the skin. Blood flukes have a cylindrical shape rather than being flattened. So the first one is Schistosoma mansoni, found in Africa, South America, West Indies, and Puerto Rico. It lives in venules of the large intestine. Eggs are found in the feces, and this particular organism has a large oval egg with a prominent lateral spine. So it has a spine on the side, or a pointed feature. The next blood fluke is the Schistosoma japonicum, found in the Far East, including Japan, China, and the Philippines. This lives in the venules, or small veins, of the small intestine. Eggs are found in feces. They're round eggs that have a small rudimentary spine. It's a very small spine, if any, that you can see. The third schistosoma blood fluke is Schistosoma haematobium, and this is primarily found in Nile Valley in the Mideast and East Africa. It lives in the veins surrounding the bladder. Eggs are found in urine, and the best time to collect eggs is in the early afternoon. They have an elongated egg with a terminal spine, so it's kind of pointed at the one end of the egg. So that's the Schistosoma species causing, or they're called your blood flukes. Let's talk about tapeworms next. Tapeworms can range in size from 3 millimeters to 10 meters. That's very long. They generally require an intermediate host in their life cycle, and they are hermaphroditic. Important note. Tapeworms have these ribbon-like growth sections called proglottids. The head of a tapeworm is called a scolex. Eggs contain a hexacanth embryo, or an oncosphere, that is infective to the intermediate host. More about the proglottid segments that tapeworms have. When the worm is mature, these proglottids produce eggs that are infective to intermediate hosts, and they actually shed these body segments that contain these eggs into human feces, and then the feces are excreted. Transmission to humans involves ingestion of the larval stage. Diagnosis of a tapeworm is made by finding eggs in feces, and proglottids can also be present in feces. So the first tapeworm we'll talk about is the fish tapeworm, and this is Diphyllobothrium latum. These are found worldwide. In the U.S., it's primarily seen around the Great Lakes up near Michigan. You would look for a scolex, a proglottid, or an egg in a patient's feces. The eggs are small. There's no shoulders at the operculum. There's a small knob at the end. There are some Taenia species. These are tapeworms as well. There is a Taenia saginata, which is the beef tapeworm, and then a Taenia solium, which is the pork tapeworm. And these eggs are distinctive in that they have a very thick wall and radial striations in it. The eggs of the two species of Taenia are indistinguishable. Let's talk about a couple more tapeworms, and this is the Hymenoplepsis tapeworms. And there's two particular species, Hymenoplepsis nana and Hymenoplepsis diminuta. Nana is the dwarf tapeworm. Egg is the diagnostic stage, has filaments at polar ends. And then the Hymenoplepsis diminuta is the rat tapeworm. And so we would acquire this by ingesting infected fleas. The egg virtually identical to Nana with no polar filaments, however. There's another tapeworm called the dog tapeworm, and this is Diphyllidium canium. Humans serve as an accidental host. Children are most often infected by ingesting fleas containing the larval stage. The eggs are characteristically seen in packets of 10 to 25 eggs. This is a unique characteristic of Diphyllidium canium. Next, we're going to talk about roundworms that infect humans, and these include those that occupy the intestinal tract, blood, and tissue. These organisms are transmitted by ingesting an embryonated egg, direct penetration to the skin by larvae in the soil, or an insect vector. Intestinal roundworms are the most common helminths that infect humans in the U.S. So one roundworm is the pinworm, and we talked about the cellophane tape prep earlier for this organism. And this organism is termed, or its official name is Enterobius vermicularis, so it's termed the pinworm. It's a worldwide parasite, common in children. The female species migrates to the perianal area to lay eggs at night. Very easily transmitted. There's something called a retroinfection with this organism, and this is where hatched larva re-enters the intestine to mature into an adult. So it lives in the perianal area and can reinfect you repeatedly. Cellophane tape prep is our lab diagnostic tool. They're very typical eggs that are oval with a flattened side. Another roundworm is the Trichinella spiralis. This causes trichinellosis. So that's just another one worth mentioning. Let's talk about the Trichuris tricura, and this is the whipworm, also known as the whipworm, found worldwide. It's a barrel-shaped eggs, have a thick wall and hyaline polar plugs at each end. There is another organism called Ascaris lumbricoides, and very common, and infects up to 1 billion people worldwide per year. Eggs are oval and usually have a thick hyaline wall. Most eggs have a brown bile-stained mammillated outer layer. Let's talk about hookworms. There are two that I want to talk about. Hookworms, one called Necator americanus. This is known as the New World hookworm, endemic in southeastern U.S., South America and Central America, found in Africa and Southeast Asia. And then there's another hookworm called Ancyclostoma duodenale, and this is the Old World hookworm, found in Europe and Northern Africa and around the Mediterranean. Adult worms can be differentiated by morphology because eggs are identical. So hookworm eggs are identical. There is a couple forms to know in the hookworm life cycle. The eggs are deposited in the soil, and these are the eggs will develop into a rhabdidiform larva. The rhabdidiform larva will ultimately change into a non-feeding infective form called a filariform larva at about 1 week after depositing into the soil. And then humans are infected when the filariform larva penetrates the skin in a cut, most likely. So to identify hookworms, we have to use morphology, adult morphology. And the rhabdidiform larvae have a distinct look with long buccal capsules and inconspicuous genital primordium. So usually the rhabdidiform larvae are the diagnostic stage. There's another worm called the threadworm. It is the Strongyloides stercoralis, and this inhabits the small intestine. It can also exist as a free-living worm. This is endemic in the tropics and subtropics. In the U.S., most cases are found in people living in Appalachia or in rural areas of Southeast. And this causes a chronic mild diarrheal disease, usually seen in immunocompromised patients. We would diagnose Strongyloides stercoralis in its rhabdidiform larval stage. These have a short buccal capsule. Buccal meaning mouth. That's another term for mouth. It has a large esophageal bulb and a prominent genital primordium. Larvae can be found in sputum of patients with something called a hyperinfection. It's worth noting. I mentioned Trichinella spiralis back with our roundworms. I just want to make note that this is a larva that infects, or its larva stage infects muscle tissue. Usually we humans acquire it by eating larvae and undercooked meat, especially pork. So biopsy to determine if you have an infection with Trichinella spiralis is done on a muscle tissue, and it has this encapsulated coiled larva, which is diagnostic in the muscle tissue. Okay, we're going to talk about one more small group of worms, and then we'll be done with this chapter. It's a lot of information, I know. It's hard to keep it all organized and straight because there are several types of worms and helminths and amoeba. And it can be its own college course because there's so much more than just what we're talking about. So this last group is the filarial worms. These are essentially roundworms of blood and tissue that give birth to larvae referred to as microfilariae. We identify various species depending on the morphology of the microfilaria, its location in the host. Adult filarial worms live in human lymphatic systems, muscles, or connective tissues. And we ingest these microfilariae with use of an insect vector. Let me back that up. I said that all wrong. Okay, microfilaria in human hosts are ingested by an insect vector. So an insect vector is the location where it will develop into filaria or filiform larvae. Let's see. So these roundworms produce larvae called microfilariae. That's how we ID the species. We ingest, the insect will acquire them from us and develop these microfilariae into filariform. So one organism is Wuchereria bancrofti, and this causes something called elephantitis of your extremities. Usually it's only found in the tropics. There is a mosquito vector, and this microfilariae, which is how we ID them, is sheathed. It has nuclei that do not extend to the tip of the tail. The next organism is Brugia malayi, seen in the Far East, in China, Korea, and the Philippines. It also has a mosquito vector. Pathology and symptoms are the same as Wuchereria bancrofti. It has a sheathed microfilaria, and the nuclei extend to the tip, but there's a space that separates the two terminal nuclei that it has. And then there's the Loa loa eyeworm. This is seen in African equatorial rainforest region. There's a fly vector for this organism. The adult worm can often be seen migrating across the surface of the eye. That's where it gets its name, the eyeworm. Microfilaria are sheathed, and the nuclei extend to the end of the tail. And then there's one more organism that's a filarial worm, and this is the Onchocerca volvulus, and this causes something called river blindness, and this is found in Africa and Central and South America. The vector is the black fly. Blindness occurs when the microfilaria collect in the cornea and the iris and cause keratitis and atrophy of the iris. Microfilaria of this organism have no sheath, and nuclei do not extend to the tip of the tail. So just a little bit about filarial worms. There's 4 of them. And I believe that's all the information in your PowerPoints. So go through each one of those and really try to become familiar with these different organisms. They're unique. They're very different than bacteria. They look different. They cause different diseases. Vectors are involved. They have unique life cycles. They're just interesting. So try hard to learn and be familiar with each of these. And that's all I have to say about diagnostic parasitology.